Hello class, last week there was an exam, so I did not have the time to take, and now we will continue. So finished with esophagus, and the next topic after esophagus is stomach. Stomach is quite important. Why? Because stomach has about 4 to 5 long questions and a lot of short questions that appear every year. If not a long question, stomach is asked as 2 shorts and then 1 very short, about 3 questions every month. Stomach and duodenum every year. Stomach and duodenum carry in theory, and then you have entrance. The less said the better. So many questions. So probably I may not be able to finish stomach in less number of classes like I did with esophagus. I would probably need nearly 5 classes. I'll go slow if I have to finish certain things, and if I have to start something else next, so I may take only 45 minutes of the class, or probably less than 45. But I want a full continuation, and stomach is quite important in every aspect, and it is something that you may have to deal with day-to-day practice in your with plain MBBS career also. Stomach, esophagus, they cannot be neglected. So in your clinical practice it is important, in a day-to-day life it is important, theoretical point of view it is important as well as practical. So I will start and now continue with stomach. So you all know what stomach is. Stomach is the first organ that takes food and that starts producing acid, which will convert the food bolus into a softer version, and that is fed into the esophagus. So you have to remember how stomach is. Stomach is stomach is a tube. Yes, it's a tube. It has got a lesser curvature, it has got a greater curvature. It has got a gastroesophageal junction, it has got a fundus, it's got a body, it has got a pylorus, and then pylorus will lead to your your duodenum. Pylorus, end of that will start as duodenum. So stomach has got a lesser curvature and a greater curvature. These are covered by lesser omentum and the greater omentum. They've got multiple lymph nodes. And what does stomach do? Stomach exactly produces acid, it produces ghrelin, it produces other juices that will cause dilatation that could propensate digestion. So stomach is there, and then first you need to know about the embryology. Embryology of the stomach also is important, very important. The stomach arises from a dilatation in the tubular embryonic foregut. Yes, stomach also comes from the foregut, as esophagus comes. Assumes and then it assumes a normal asymmetric shape and position by the end of the 7th week. Just excuse me. Okay, by the 7th week, it forms an asymmetric shape. And position. It takes an asymmetric position, and then by the end of the 7th week, it assumes its normal shape. During the 6th to 10th week periods, during the 6th to 10th week periods, the stomach enlarges and rotates a 90 degree in the clockwise direction to come into its position. So that takes 6th to 10th week. How does it develop? Stomach develops from dilatation of the tubular foregut. Then arterial supply of stomach. It is supplied by on the lesser omentum or the lesser curvature, supplied by the left and the right gastric arteries. On the greater curvature, left and the right gastroepiploic arteries, and above posterior and anterior gastric arteries in the early part. Okay, at the fundus level, above near to the gastroesophageal junction, it is supplied by posterior gastric artery and anterior gastric arteries. Lateral gastric arteries. Lesser curvature is supplied by right and the left gastric arteries, and then greater curvature is supplied by gastroepiploic arteries. Left and right gastric arteries are direct branches of left gastric artery is the direct branch of the celiac trunk. Celiac axis is the main trunk from which stomach's blood supply comes. Then you have to remember that right gastric artery is a branch of common hepatic artery. Gastroepiploic arteries are branches of gastroduodenal arteries, and right and left gastric arteries are direct small short branches of the celiac trunk. There are about 17 stations of lymph nodal group, which will be little too much for you, but I'll try to help you or try to explain it to you better when we are dealing with CA stomach. Okay, CA stomach, I'll try to tell in more details. Then you have innervation of the stomach. So it is basically a performing organ, so both sympathetic and parasympathetic nerve supply is to be there. Sympathetic and parasympathetic nerve supply is to be there. So how does it do? It has got an extrinsic innervation, it has got an intrinsic innervation. The extrinsic innervation of the stomach is both parasympathetic through the vagus and sympathetic through the celiac plexus. The vagus nerve originates where? In the vagus nucleus at the fourth ventricle and traverses the neck in the carotid sheath and then comes down, and then it enters the mediastinum. I'm trying to explain you how this vagus nerve comes down to your stomach. Okay, then it traverses through the carotid sheath. It further comes down into the mediastinum, where it divides into several branches. Okay, it gets divided into several branches around the esophagus, and traverses the branches all coalesce. They join together above the esophageal hiatus to form left and the right vagus. The separated branches, they all coalesce, and at the end of the gastroesophageal junction, where it is dividing the diaphragm, they get converted into two nerves, that is left vagus and the right vagus. So exactly where is the anatomy of the left or the right vagus? At the GE junction. Okay, at the GE junction, the left vagus and the left vagus is anterior and right vagus is on the posterior aspect. Left vagus anterior, LA. Right vagus is on the posterior side. Okay, that is how it gets converted at the entry point of your diaphragm at the gastroesophageal junction. Now, how exactly it's going to work? The left vagus is anterior at the G junction, and the left vagus gives a hepatic branch. The left vagus gives a hepatic branch to the liver and then continues on the lesser curvature, as the anterior nerve of Lethardjet. Why I'm telling you these intricacy points is, we will come to them when we are dealing with gastric ulcer and their surgeries. Okay, but I'll try to explain them before. But when I be teaching that, it will be more beneficial for you. At the GE junction, the right vagus, is posterior. Okay, and this has got something called as the criminal nerve of Grasse. Most of the times people miss this and the acid peptic disease comes back. Okay, this is called as criminal nerve of Grasse. It is the first branch of the right in the posterior vagus and is recognized as potential etiology for recurrent gastric ulcers. Within the left undivided. Then right vagus also gives a branch off to the celiac plexus and continues posterior along with the lesser curvature. So right, I already told you on the lesser curvature, it gives a posterior branch to the celiac plexus, and then from there on it continues below. Okay, now as I said previously that in treatment of gastric ulcers we come across these terms, that is, and why this criminal nerve of Grasse or or the nerve of Lethardjet, all we will be discussing here. So in the when we do gastric ulcer treatment, operative treatment, what we perform is a vagotomy. Okay, there are different types of vagotomies. That is totally truncal vagotomy, selective vagotomy, highly selective vagotomy. For recurrent gastric ulcers, we will do something called as vagotomy plus a enterectomy. So that way, when I'm dealing with ulcer only, I'll be talking about. But right now, you should remember that there are three types of vagotomies: truncal vagotomy, number one; selective vagotomy, highly selective vagotomy. So when you do a truncal vagotomy, what you do is you perform it above the celiac and hepatic branches of the vagus. Okay, at the celiac and the hepatic branches of the vagus, you perform this surgery at the celiac and above the celiac and hepatic branches of the vagus. Then both the vagus, you call it as vagi. Okay, then you will come to something called as selective vagotomy. In selective vagotomy, you do it just below. Okay, just below the celiac and the hepatic branches of the vagus. Then in highly selective vagotomy, you will perform it at the feet of the crow. Okay, at the feet of the crow, in the proximal part of the stomach, while preserving the innovation. You will have to preserve antrum as well as the pyloric part. That is where you will do a highly selective vagotomy. Only you will cut those crow dividing feet of the innervation of the vagus into the stomach. This is about highly selective vagotomy. Okay, highly selective vagotomy. Now, what exactly is the histology of your stomach? It has got a mucosa, it's got a submucosa, it has got a muscularis propria, and then a serosa. Which is the strongest layer? As I told you, whole of the GI tract, it is the submucosa. Please remember, submucosa is the strongest layer of the GI tract. Okay, so what happens here? This particular differentiation is there. The stomach has got a rugae which will allow it to stretch. Okay, which will allow it to stretch to a certain limit, to a lot of a limit. That's the reason people go on eating and they put on weight, they become fat. So the stomach has got the ability to stretch, and over a period of time it will get acclimatized to even bigger food. That's the reason you can eat a lot as you start eating. Initially you stop eating, your your stomach will become small, and you suddenly cannot eat full biryani. Probably you'll eat only 1/3 or 1/4 of half of biryani, and then as you keep on eating, it will increase its size. It will increase its size as you grow up. The stomach size increases. That also will lead to you becoming obese. Becoming obese. Then, what are the cells that are present in the stomach? The stomach has got location of cells. That is two places. One is body, and then is antrum. Okay, body and antrum. In body you have mucus cells. Okay, mucus cells, chief cells, MCD. The full form you have to put it as MCD. Mucus cells, chief cells, B cells, parietal cells, and interneurons and ECL cells. Okay, MCD pi, that is MCD pi. Okay, then you have GD antrum, that is gastric antrum. You have to remember GDGI. It has got mucus cells, it has got D cells, it has got G cells, and it has got interneurons. Parietal cells secrete. Okay, parietal cells secrete ghrelin, intrinsic factor, leptin, and acid. Parietal cells secrete the most important ghrelin, intrinsic factor, leptin, and acid. So you have to remember all the four names. These are secreted by the parietal cells, and then the chief cells secrete pepsin and leptin. And in the histology, you will have about 44% of them are chief cells, 40% of them are mucus cells, parietal cells are about 13%, and endocrine cells are about 3%. Endocrine cells are about 3%. These all help us in your stomach acting as a digestive organ. First digestive organ. After this, what happens? Once this happens, then there are submucosal glands in the duodenum that are called Brunner's glands. It was asked for me in my entrance bit. What did they ask is, which is the gland that is absent in the stomach? And the option was Brunner's gland. They gave parietal cells. It's an easy question basically. Brunner's glands are absent. So if they ask you what are the glands that are present in the duodenum, you may get confused. So it is Brunner's glands in the submucosa of the duodenum. Okay. Then you will have ghrelin. This is an important hormone, and this was asked as entrance previously. So it is secreted by the oxyntic cells and the fundus of the stomach, ghrelin. First gut peptide. It's the first gut peptide to have, or that is appetite stimulating. It is also called as orexigenic. Then orexigenic properties, that is appetite stimulating. Also, whenever people have less hunger, it means their ghrelin levels are low. Then the circulating levels of ghrelin are inversely related to BMI. Okay, they are inversely related. Okay, adipose tissue mass and plasma insulin levels. So why is it important? Ghrelin levels, whenever there is large amount of ghrelin hormone getting circulating in the body, which means it is when these are more, the BMI is low, the fat content is low, and plasma insulin levels are also low. Okay, they are basically inversely related to BMI, adipose tissue mass, as well as your plasma insulin levels. Primary effects of ghrelin, what are the functions of, or what are the things that this hormone does, is it has got a motilin-like effect, which will cause gastric motility. So increase emptying time, faster emptying time, that is more ghrelin, faster emptying time, so less chances of absorption and thereby less fat mass. Okay, then it allows, or it causes the release of somatostatin and PP. Stimulates growth hormone. It stimulates growth hormone from the pituitary, that is anterior pituitary. Yes. Then now we will come to stomach proper. What are the problems that come to the stomach? So stomach can have a lot of diseases. Okay, it has got a gastric it has got gastritis. It has got many types of gastritis. It has got many infections. It has got cancers. It has got motility disorders. It has got pyloric stenosis, that is gastric outlet obstruction. There is one particular point about gastric outlet obstruction. Any gastric outlet obstruction in the present scenario, unless and until proven otherwise, should be considered or should be treated as malignancy. GOO, gastric outlet obstruction. So it has got so many problems. It has got congenital defects that I'll be dealing along with the duodenum. It has got some vascular anomalies. I may forget when I'm actually dealing with the class. There is something called as Dielerflaus lesion. A Dielerflaus lesion is nothing but it is a abnormal left gastric artery which comes into the submucosa, and opens up. It's a tortuous left gastric artery branch which comes into the submucosa, and whenever it ulcerates and bleeds, it bleeds so bad that we may have to do a gastrectomy. We may have to do a partial gastrectomy. Dielerflaus lesion. I may forget, I may not remember. That's the reason I'm talking about it. Now the most important, the way the stomach ulcer, gastric ulcer, duodenal ulcer, CA stomach, lymphoma of the stomach have evolved is by this particular organism, and its identification and culture got two people a Nobel for medicine. It is nothing but H. pylori or Helicobacter pylori. Helicobacter pylori was first in vivo, that is in lab, was first cultured by Marshall and Warren. Marshall and Warren cultured H. pylori, for the first time, and that brought them a Nobel. What are the names of these two great gentlemen? Marshall and Warren. And then a whole plethora of problems that this organism caused, and how it really works, how it gets to be eliminated, how it is involved in formation of the gastric malignancies. All of them have taken a different turn. So it is called as it was first cultured in vivo by Marshall and Warren, and they got a Nobel for medicine. Now they named it, when they first found it, as Campylobacter pyloritis. Campylobacter pyloritis. When they first identified and cultured it in the lab, they named it as Campylobacter pyloritis. Why is this organism, why its identification, why its culture, why its name has so much importance is, let me tell you, it causes about 75% of gastric ulcers, 90% of duodenal ulcers, and it is associated with CA stomach and malt lymphoma. it has also got effect on GERD and squamous cell carcinoma. There is a separate strain. There is a separate strain which causes, which actually, it's a funny thing. It prevents adenocarcinoma of the esophagus, but at the same time, it activates the chances of patient developing squamous cell carcinoma. Squamous cell carcinoma. So this particular organism is so important. And why it is important? In such an acidic environment, about pH of 1.1, survival of an organism is so difficult. Yet this organism makes that as a place for it to survive. And that is done by the enzyme urease. That's the reason this particular organism is so important. Its elimination is important. It's after elimination, what do you do is important. Before elimination, what test you do is important. So H. pylori, the people who have identified it were Marshall and Warren. Okay, and remember, it can stay, or it can only stay in the gastric epithelium. It can only stay in gastric epithelium and nowhere, because the gastric epithelium expresses a certain antigens, a certain specific epithelium expresses an adherence receptor that this particular organism is found of, or this particular organism recognizes it. Also, it is not just found in the stomach or in the duodenum, but it is also found wherever there exists a gastric epithelial mucosa. So whenever there is a heterotrophic gastric mucosa, where do you see them? You will see them in a proximal esophagus. You will see them in the duodenum. You will see them in the Barrett's esophagus. You will see them in the persistent vitellointestinal duct. What is that called? As Meckel's diverticulum. You will see whenever there is a gastric type of mucosal change in the duodenum, you will find it there. You will find it in heterotrophic gastric mucosa, sometimes found in the rectum. It only survives in that particular epithelium because of its adherence property. Nowhere else. So usually it is seen in people with low socioeconomic groups. After that's the reason more people are poor, less people are rich. So poor people usually have this in there, and they contact it during their childhood. Okay, na? There tends to be an inverse relationship between infection and the socioeconomic status. If you're rich, the infection chances are less. If you're poor, the infection chances are high. How does this H. pylori survive in your body? How does H. pylori promote ulcer formation or acidities? It basically stimulates release of gastrin, inhibition of somatostatin release, interruption in inhibitory vagal reflexes, and inhibition of gastroduodenal bicarbonate secretion. What are the four causes? What are the four reasons why it forms ulceration? It stimulates release of gastrin. It inhibits release of somatostatin. It causes interruption in vagal reflexes. If vagus reflexes are high, the chances of gastric output are very, very, very high. So it inhibits that, and then it inhibits gastroduodenal bicarbonate secretion. Once acidic environment, and then it causes. And once the spontaneous remission. Once a person is infected with H. pylori or Helicobacter pylori, the chances of spontaneous remission are zero. That is rare. At the same time, once you are cured of this particular organism in the stomach, its recurrence also is rare. Now, these are the salient things that this particular organism causes. Now, what is this H. pylori, Helicobacter pylori? It is a spiral-shaped bacteria. Okay, it's a spiral-shaped bacteria with a Lophotrichus flagella. Lophotrichus flagella. It's a rod, basically a bacilli. It's a rod. It is a gram-negative organism. Gram-negative organism. The sole source of this particular organism is the gastric mucosa. Okay, what are the three hormones, or sorry, three? What are the three? It's not biochemical reaction. I forgot. If I remember it in this course, I'll tell you. But what are the things that basically this particular organism releases? The biochemical reactions is something. It's called as something I don't know. Okay, enzymes. Okay, no. What are the three enzymes that it releases? It releases urease, which is more important for the survival. It releases catalase and it releases oxidase. These are the three biochemical reactions usually that takes place or that are released by this. Grows well when incubated at 37 degrees. Okay, at normal room at your body temperature. If you incubate it in a micro-aerophilic condition, it will grow. Okay, and what are the media that are used for H. pylori also are important. You use a chocolate medium. Okay, you use a chocolate medium and also a Skirrose medium. You also use a Skirrose medium. Now, pathogenesis. How does this bloody organism affects us? It grows optimally at 6 to 7 degree pH and would be killed at pH within the gastric lumen. Okay, and would be killed at that particular thing. But it survives as it is found in the deep mucosal layer near the epithelial surface. Okay, without invading, it does not invade the mucosa at all. Okay, and where the physiology is not conducive to it, because the gastric mucosa, if it invades the gastric mucosa, it will die. That's the reason it won't. So it will just remain below. Okay, just remain below, and it produces a very potent urease. I already told you about this enzyme, urease, which provides ammonia. Okay, this urease breaks ammonia, urea to ammonia, and this ammonia acts as a buffer. Okay, it acts as a buffer and thereby prevents its death. Major diseases that are associated with H. pylori virulence is because of the vacuolating cytokines, VACA, okay, and group of genes that are produced. Now, H. pylori colonization decreases somatostatin producing cells, okay, and thereby increasing gastrin. Thereby it increases acid protection, and this causes gastric metaplasia and this dysplasia and this metaplasia in the duodenum, because 90% of duodenals is because of this. So this metaplasia causes duodenal metaplasia to squamous metaplasia of the stomach, and then that will lead to ulceration. Now, what are the diseases that this particular organism causes? 90% of the duodenal ulcers, 75% of the gastric ulcers. It causes increased risk of gastric adenocarcinoma, gastric malt lymphoma. I already told you, because it changes the whole thing. Extra gastrointestinal pathologies also have been noted by this particular organism. So it causes ischemic heart disease and a cerebrovascular attack. There is something called as a variant of this H. pylori, CAGA positive strain, capital C, capital A, capital G dash capital A strain. Okay, I already told you about this. It is protective against the adenocarcinoma of the esophagus, but will lead to squamous cell carcinoma of the esophagus. Squamous cell carcinoma of the esophagus. How do you diagnose? How do you diagnose this H. pylori? H. pylori, how do you diagnose? It is diagnosed, okay? It is diagnosed by visualization of the H. pylori is the gold standard investigation of choice, okay? Visualization of the H. pylori is gold standard investigation. You have to identify the organism, and what are the strains that you use for visualization? Giemsa strain, silver strain, okay, silver stain, Giemsa stain, and also Warthin starry stain. Warthin starry stain. These are the three stains which will allow us to help us visualize the bacteria. The method of choice of diagnosis. For H. pylori is basically endoscopic rapid urease test. Okay, rapid urease test. Serology you can do, but for basically doing an initial diagnosis, not for a complete diagnosis. Okay, after treatment, urea breath test. Okay, you have to do after the elimination, after giving drugs. You have to do a rapid or urease breath test to know if the organism has vanished after treatment of 4 weeks. But accurate diagnostic methods are these. Chronic gastric inflammation on the gastric mucosa, you will take a biopsy, and this test is 100% sensitive. Biopsy of the inflamed gastric mucosa is the gold standard, actually the test that has got 100% sensitivity. Rapid urease test on a gastric mucosal biopsy specimen. There you have to see a biopsy, and in that the organism. Whereas in the most 100% specific test, okay, the 100% specific test is when you subject the inflamed mucosa to rapid urease test. Okay, to rapid urease test. If you subject that particular organism to that is when you will see. That is when you will identify. That is when the test becomes 100% specific. 100% specific. So much disturbance. Then, how do you assess the treatment eradication of H. pylori? This is very important because it has been asked. Assessment should be done at least 4 weeks after 4 weeks treatment. Okay, that is called as H. pylori kit. You give the patient. It has got aluminum hydroxide, it has got pantoprazole, and it has got two antibiotics. We will be talking about it later. But yeah, after completion of 4 weeks of test, for 4 weeks of treatment, there are both the ways. Successful assessment can be done by endoscopic biopsy again, or there are tests where you will not need any invasion, and that test is called as rapid urea breath test. rapid urea breath test. This is how you identify successful eradication of H. pylori. H. pylori. So non-invasive tests are preferred for after treatment assessment. Basically, non-invasive tests are preferred. Urea breath test of choice, as I already told you, for documenting eradication. Then there is something called as stool antigen test. Okay, stool antigen test. If urea breath test is not allowed, then you will do a stool antigen test after eradication, after giving the drugs. Okay, then you can do a serological testing, but it is not really useful. Not really useful. Then invasive tests, again, as I told you previously, that biopsy based test, and then again you subject the biopsy to either just biopsy microscopy, or you will do a rapid UDS test. But non-invasive methods are usually preferred in checking out for the eradication of your H. pylori. Assessment of success of treatment. Okay, that is what we have identified. Now, there is an association of H. pylori. Yes, there is an association of H. pylori infection with ABO blood groups, AB blood groups. Okay, and group with, and also this AB blood group is also having a association with the pancreatic cancer. H. pylori causes something called as H. bilis. It's another friend or brother, whatever. H. bilis, Helicobacter bilis. Okay, H. bilis, Helicobacter bilis can cause or increase the risk of CA gallbladder. Can increase the risk of CA gallbladder. Okay, then what are the diseases that are associated with H. pylori? This is a question I already told you. What are the diseases that are associated with H. pylori infection? Antral predominant gastritis. Antral predominant gastritis. Corpus predominant atrophic gastritis. Corpus predominant atrophic gastritis. Duodenal ulcer, gastric adenocarcinoma. These are the 4 diseases that are very much possible. And then there are 2 non-specific diseases are there. That is malt lymphoma, I already told you. Non-atrophic pangastritis. Non-atrophic pangastritis. Please remember this when we will be discussing CA stomach etiological factors. All these things are going to come back. Then there are 2 different types of gastritis you have to remember. Chronic gastritis, there are 2 of them, type A and type B. Type B is basically associated with H. pylori, okay, and it is located in the gastric antrum. Then type A is of autoimmune etiology. Circulating antibodies in the parietal cells results in atrophy of the parietal cell mass. So circulating autoantibodies, these will kill the parietal cells. That will decrease in the parietal cell mass, resulting in hypochlorhydria and ultimately achlorhydria. Hypochlorhydria, once it gets totally atrophied, it will become achlorhydria. Circulating autoantibodies. And that will cause pernicious anemia, type A gastritis, pernicious anemia. And pernicious anemia is a precursor of cancer stomach. There it is antrum that is affected. Here it is the body and the fundus in type A gastritis. Chronic gastritis in type A, it is basically present in the body and fundus. So how do you remember type A, type B? In type B, it is because of H. pylori, located in the antrum. Type A, it is located in the, it is basically autoimmune, located in the body and fundus. Okay, and it causes atrophy of the parietal cell mass and ultimately causes first hypochlorhydria and then achlorhydria. Then achlorhydria, which will lead to pernicious anemia. And pernicious anemia in itself is a pre-malignant lesion of the stomach. Pre-malignant lesion of the stomach. Okay. Now we will come to something called as peptic ulcer. Okay, peptic ulcer. In peptic ulcer, simultaneously I will be discussing both about your gastric ulcer followed by duodenal ulcer, and then what are the commonalities, etc., etc. What are the points that are important? I'll be discussing. Now, first let me come to gastric ulcer. Gastric ulcer etiology. What are the etiological factors for gastric ulcer? Atrophic gastritis, that is pernicious anemia, chronic gastritis, type A gastritis. 75% is because of H. pylori, that is type B gastritis. Smoking, alcohol, a lower socioeconomic group, altered mucosal barriers. This is caused by NSAIDs. NSAIDs are one of the reasons, etiological conditions causing your gastric ulcer. There is a normochlorhydria or achlorhydria. If it is type A gastritis, it is achlorhydria. Otherwise, it is normochlorhydria. And sometimes, not sometimes, cirrhosis also will lead to formation of gastric ulcer. Most common site of type A gastric, that is gastric ulcer, is on the lesser curvature along the incisura angularis. Clinical features: it affects both the sexes. Pain in the epigastrium after taking food. It is relieved after vomiting. Pain is uncommon during night because you don't eat. Okay, hematemesis is a very, very common feature. Hematemesis is a very, very common finding. Appetite is good, but the patient is hesitant to eat because as he eats, he'll have acid production, and that will cause pain, and ultimately the patient will start losing weight. How do you investigate? Previously we used to do a barium studies, but now it is endoscopic studies. In barium studies, how are you going to see the gastric ulcer? There is a niche on the lesser curvature, and there is a notch on the greater curvature. Notch. So a hourglass shaped defect in the barium meal. There is regular round margin, which has a spoke-like pattern. So this is called as spoke wheel pattern. Regular round margin that creates a spoke wheel margin. Then there is something called as a overhanging mucosa. Overhanging mucosa of the ulcer. Ulcer is deep in, the mucosa is overhanging, and it falls. This fall is lined by a Hampton's line. The projection is like a line, and this line is called as Hampton's line. All these have been asked in the entrance. Sometimes. Hampton's line, spoke wheel pattern, niche and notch pattern in the greater and the lesser curvatures, and then lastly, converging mucosal folds. This will happen at the base of the ulcer. Then, what are the most common problems that can come to people with gastric ulcer? You will have perforation. Most common complication of gastric ulcer is it perforates into the lesser sac. Hourglass pattern contracture. It is more commonly seen in women due to cicatrial contracture of the lesser curvature ulcer. It's more commonly seen in women. Then there is a teapot stomach or hand-bag stomach. It's also called as teapot stomach or hand-bag stomach because of cicatrization and the shortening of the lesser curvature. The lesser curvature shortens and the teapot appearance is what you get in this thing. These are all the complications, and ultimately this will lead, and the gastric ulcer, if left untreated, 10% of them can become malignant. 10% of them can become malignant. 10% of them can become malignant. Then we will come to duodenal ulcer. In duodenal ulcer, 90% of the etiology is 90% of the times it is because of your H. pylori, stress, anxiety. Okay, stress, anxiety. There is a very funny this thing. Hurry, worry, curry. Okay, hurry. You eat quick. Worry. If you're having too much of if you have become too much of stress, then curry, spicy curry. These are all the three things that will lead to your duodenal ulcer formation. Duodenal ulcer formation. NSAIDs are the main reasons for formation of the duodenal ulcer. NSAIDs will cause duodenal ulcer. Steroids will cause duodenal ulcer. Somehow, I don't know if it is proven, blood group O positive is known to be one of the reasons, or people of O blood group are more prone to development of duodenal ulcer. Then there is something called as endocrinological diseases or problems that are causing duodenal ulcer. That is nothing but Zollinger-Ellison syndrome, MEN1, multiple endothelial neoplasia 1, Cushing's syndrome, hyperparathyroidism. All these endocrine abnormalities will cause stress gastric ulcers. Alcohol, smoking, vitamin deficiency, and chronic pancreatitis and cirrhosis will also cause duodenal ulceration. Most common site of duodenal ulceration is the first part of duodenum, and it is also the most common location or most common site for a peptic ulcer. For stomach, what was it? For a stomach, it was at the incisura angularis on the lesser curvature. For duodenum, it's for the first part of the duodenum. So what are the clinical features that this patient will come to you with? It's more common in men. Okay, pain is early in the morning, decreases after eating. So the patient keeps on eating to decrease the pain of this particular ulcer. So what happens? The fellow will become obese. There the patient will lose weight. Here this patient will gain weight. Pain is very, very common during the night hours. In the nights, the pain is very, very, very common. There I said hematemesis is a common symptom, but here it is melena. Appetite is good, eats more frequently, so the patient will have weight gain. Features on the barium meal. Okay, what we were discussing, barium meal. What does it happen in barium meal? There I said niche notch. Okay, a spoke wheel, then your spoke wheel, niche notch, then what else did I speak? Niche notch, spoke wheel pattern, Hampton's line, right? And then there is mucosal fold overlapping, that is called as converging mucosal folds, and that is at the base of the ulcer. In the duodenal ulcer, you will have a deformed or an absent duodenal cap. And what is this duodenal cap? It's nothing but there is basically a dilatation at the pyloric end where the duodenum meets the stomach. There's a little dilatation. This dilatation appears like a cap to your duodenum, and this cap is lost because of cicatrization. This cap is lost. Appearance of trifoliate duodenum. Appearance of trifoliate duodenum secondary due to the duodenal diverticula that is formed because of duodenal ulcers. The most common complications of duodenal ulcer is bleeding, okay, bleeding, and the posterior wall, and the artery that is involved is gastroduodenal artery. Perforation is more common in the anterior wall. If posterior, it will be into the pancreas. So most of the times it is common on the anterior wall. Gastric outlet obstruction, that is pyloric stenosis, is seen in duodenal ulcers, and then most of the duodenal ulcers are all the duodenal ulcers are non-malignant. Now, specific chronic disorders associated with peptic ulcer disease. You should remember strong associations are seen in systemic mastocytosis, chronic pulmonary disease, chronic renal failure, liver cirrhosis, nephrolithiasis, alpha-1 antitrypsin deficiency. Very strong association with peptic ulcer disease. These are the diseases, that is systemic mastocytosis, chronic pulmonary disease, chronic renal failure, cirrhosis, alpha-1 antitrypsin deficiency, nephrolithiasis and liver cirrhosis. Relatively possible associations are hyperparathyroidism, I already told you, duodenal ulcer, then coronary artery disease, polycythemia vera. Polycythemia vera is common in people who smoke and high altitude climbers. Chronic pancreatitis. This is a doubtful association, possible association, whereas a strong association is seen in systemic mastocytosis. They've all been asked in entrances. Systemic mastocytosis, chronic pulmonary disease, chronic renal disease, liver cirrhosis, nephrolithiasis, alpha-1 antitrypsin deficiency. Pathophysiologic abnormalities in peptic ulcer. Decreases duodenal what exactly is the pathophysiology that is happening? It decreases the bicarbonate secretion by the duodenum in duodenal ulcer, increases nocturnal acid secretion, increased duodenal acid load. Secretion is high, load is also high. Increased daytime acid secretion, increased prostaglandin stimulated MAO. MAO is nothing but MAO. What is MAO? Oxidase, increased gastric emptying, okay. MAO inhibitors, there is a drug also. This causes increased in gastric emptying and decreased pH because of the gastrin release, and the gastric ulcer formation is because of increased serum levels of pepsinogen 2, increased duodenogastric reflux, decreased gastric parietal cell mass, that is atrophic gastritis, and then decreased maximal acid output. Maximal acid output. What are the location? Okay, what are the location of the ulcers? Number one, lesser curvature near the incisura angularis is the most common location in the stomach. Here acid secretion is basically low. Then body of the stomach and the duodenum, acid secretion is quite high. Okay, body of the stomach and duodenum. Pre-pylorus, that is within 3 centimeters of pyloric antrum. Okay, pyloric antrum, high acid output. Then high of the lesser curvature near to the gastroesophageal junction, low gastric output, and anywhere induced by medications, NSAIDs, the acid secretion is low. Okay. Then there are some specific important points on your gastric ulcers that you should remember. Most common type of gastric ulcer is type 1 gastric ulcer. It is located near the incisura angularis along the lesser curvature. NSAIDs ulcers are basically type 5 ulcers. NSAIDs, modified Johnson's classification, that's what I said, where the lesser curvature, body of stomach, pre-pyloric, that is called as modified Johnson's classification. So gastric ulcer type 5 typically occurs at the antrum, but it can come anywhere in the stomach. But typically it occurs at your antrum. Type 2 and 3 have very high acid secretion. What are the type 2 and 3? At the body of the stomach and duodenum and the pre-pyloric area, the acid secretion is high. Rest of them it is low. Type 1, type 3 and type 4 and 5, the acid secretion is low. Type 2 and 3 basically have high acid secretion again. Then you have type 1 and 4, normal to low acid secretion association. Type 1, type 1, that is incisura angularis, gastric ulcer, is associated with blood group A. So once again, modified Johnson's criteria. Number 1 is lesser curvature near to the incisura angularis. The acid output is low. Number 2 is body of the stomach and duodenum, acid output is high. Then pre-pylorus, acid output is high, type 3. Type 4 is higher on the lesser curvature near to the gastroesophageal junction, acid secretion is low, and anywhere, because of the NSAIDs, anywhere which is more common, nearly more common, location is at the antrum, and this is causing NSAID. This is caused by NSAIDs, and the acid output here is very low, very low. Then duodenal documented evidence of eradication of H. pylori in patients with peptic ulcer disease basically is associated with, once you treat the patient for this, it is associated with 20% decrease in ulceration and 59% decrease in gastric ulcers and the duodenal ulcers. Ulcer recurrence decreases by 20%. Magnesium containing drugs will cause diarrhea. Aluminum containing drugs will cause constipation. Why I'm telling you this is when we talk about further complications and all, I'm going to tell you something, treatment of gastric ulcer and duodenal ulcer. When I'll be talking about H. pylori kits. These H. pylori kits will discuss what are the things that are present. Clinical features that are already discussed: pain, bleeding, after eating, before eating, weight gain, weight loss. These are all these things. So this is about gastric ulcer and peptic ulcer disease that we have discussed. Anybody has got some doubts? The next will be peptic ulcer complications and treatment on one day, and then we will move to the other topics. Anybody has any doubts to ask? Let me see my mobile. Any doubts? No doubts? What kind of metabolic changes occurs due to ulcer? See, basically ulcers by themselves don't cause any metabolic changes. Ulcers by themselves don't cause any metabolic changes, but yes, the complications of ulcers that I'll be discussing next will cause metabolic changes, that is hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. This is what is caused by complication that is called as gastric outlet obstruction. In particular, ulcer in itself won't cause any metabolic change. Any more? Yes. Smoking has got a high predilection for both gastric and duodenal ulcer. No, people with alpha-1 antitrypsin deficiency, that is seen in your what is that? Emphysema of the lungs. Yes, those people have this ulceration, but that is also because of smoking. Alpha-1 antitrypsin deficiency also is because of smoking, and that is not a clear indication here. Smoking in itself causes ulceration, and a smoking related problem, alpha-1 antitrypsin deficiency in the lung, can lead to formation of ulcers in the stomach. See, somebody can get stomach ulcers at 45, 50, 55, 60, whereas emphysema is only after 60. Yes or no? After the 6th decade. Emphysema is after 6th decade. So yes, alpha-1 antitrypsin deficiency also is associated with smoking, as well as peptic ulcer disease. This peptic ulcer disease is also associated with smoking. Smoking is an ulcer causing entity, but the alpha-1 antitrypsin deficiency due to smoking and smoking in itself are two different entities that will cause peptic ulcer disease. Okay, done? Or any more questions? Vaibhavanand. How will we differentiate gastric ulcer and duodenal ulcer clinically? See, there is nothing you can basically do clinically that will present to you with this thing. And if only it's a duodenal ulcer and it has got pyloric stenosis, it has caused pyloric stenosis, that is when you will have a mass-like feeling, succussion, splash, and etc. clinically to examine. But clinically you can understand what by the patient's history. Like if the patient eats and his pain decreases, he eats more, so he'll become fat. And if the person eats and the pain is there, so he will try to induce vomiting, or he vomits and the pain releases. So he does not like to eat, so he avoids eating. So once he avoids eating, he'll be thin, he'll lose weight. So that way you can differentiate, you can come to an idea, but it is not clearly on a clinical basis that you can you can come to a conclusion whether the patient is suffering from a gastric ulcer or the duodenal ulcer. Only thing is, if the patient is fat, probably it is duodenal ulcer. The patient has become thin, it is gastric ulcer. Yeah, if there is a complication that is pyloric stenosis because of duodenal ulceration, then you can easily identify that. Anyone else? Okay, then done. Have a great weekend. Bye.